What is neonatal sepsis? Neonatal sepsis happens when any pathogenic organism is entering into the blood. So the sepsis can be localized or it can be generalized. Okay. So what happens if the sepsis is localized? Means it is the organisms are localized in a particular organ of the neonate. For example, if the organisms are present inside the lungs, it will create pneumonia. If it is localized in the meninges, it will cause meningitis. And if it is affecting the bones and the joints of the baby, it will cause osteomyelitis and arthritis. So neonatal sepsis is a very important topic. It is very commonly seen in neonatology practice. Okay. So I have taken this table from Opighai textbook of pediatrics. Just know the classification. Neonatal sepsis can be early onset and it can be late onset. So what do you mean by early onset? If there is onset of sepsis within the first 72 hours, and if it is more than if the onset is more than 72 hours, it is called late onset. So what are the risk factors for early onset neonatal sepsis? The risk factors will be some perinatal risk factors. What are the perinatal risk factors? Like spontaneous onset of preterm labor. Preterm labor যদি onset হয় তখন একটা early onset neonatal sepsis হওয়ার chance থাকে. Prolonged rupture of membranes. If the membranes are ruptured, the birth passage will remain open, so there is chance of bacteria to enter into the genital tract. Foul smelling liquor. If the amniotic fluid is foul smelling, it indicates there is bacterial infection. Multiple PV examination. If they have been done multiple times, so there is chance of introduction of bacteria. Maternal fever and difficult labor or prolonged labor. But what are the risk factors for late onset? Late onset means 72 hours the baby was okay. But what happened beyond 72 hours that the baby developed symptoms and signs of sepsis? So those are mostly poor hand hygiene. Okay, the bacteria is entering the body after the baby is born. Okay, so poor hand hygiene compliance, low birth weight babies, lack of breastfeeding, poor care of the umbilical cord, superficial infections like pyoderma, umbilical sepsis. If there is aspiration of feeds, feed aspiration means what? Since the newborn swallowing mechanism is poor, particularly in the preterm newborns. So while feeding, if milk enters the respiratory tract, it can create pneumonia in the lungs. Then if there is disruption of skin integrity with needle pricks, okay, and use of IV fluids. If for some reason we started intravenous fluids, that is also creating a breach of continuity of the skin. So it is a portal of entry of bacteria. So what is the presentation? Early onset neonatal sepsis most commonly present as pneumonia, okay, and less commonly as septicemia and meningitis. But LONS mainly generalized sepsis followed by pneumonia or meningitis. Organisms are also a bit different in early onset and late onset. In developing countries we have this Klebsiella pneumoniae, Acinetobacter species, Staph aureus. Okay, of course the case fatality rate means the mortality rate is highest in early onset neonatal sepsis compared to late onset neonatal sepsis. We will discuss about this sepsis in the subsequent slides also. Again, we will talk about risk factors. We will try to understand the important risk factors. Spontaneous preterm labor in absence of premature rupture of membrane. Foul smelling liquor, pre-labor rupture of membrane more than 24 hours. This is very important, the duration, more than 24 hours. Okay. And confirmed or suspected intrauterine inflammation, infection or both. This is called triple I. Intrauterine inflammation, intrauterine infection, or both. Previously, intrauterine infection, inflammation, chorioamnionitis. There is a term called chorioamnionitis. In that condition, these things happen. Okay. So these are all risk factors of early onset neonatal sepsis. Again, if there is prolonged labor, what do you mean by prolonged labor? If the sum of the first and the second stage of labor is more than 24 hours. Okay. Single unclean vaginal examination during labor. So it will introduce bacteria in the genital tract. If there is severe perinatal asphyxia, what is perinatal asphyxia? After birth, if the baby is not crying, oxygen will not go into the brain. So it will cause hypoxic ischemic encephalopathy. And that can be a cause of, that can be a risk factor for neonatal sepsis also, early onset neonatal sepsis. So severe perinatal asphyxia with APGAR score less than 4 at 1 minute. Do you know about APGAR score? What is APGAR score? বল যেগুলো মনে পড়ছে সেগুলো বল। APGAR এ কি দেখা হয়? Appearance, pulse, grimace, activity. Okay. So কখন আমরা অ্যাসেস করি? 1 minute and 5 minutes দুবার অ্যাসেস করা হয়। ঠিক আছে? Now what are the clinical features? Let's see. So the most common clinical feature will be alteration in the established feeding behavior. Mother will say the baby is not feeding well. So this is also an indicator that it may be because of bacterial infection or sepsis. Many a time mother says, but we think mother is complaining more than stating the real scenario. But please don't ignore the mother history. You will have to, whenever a mother says ki baby is not feeding properly, you will have to assess the baby also for other symptoms and signs of sepsis. Refusal to suck. The baby is not sucking properly. And the baby is lethargic or unresponsive. The cry is poor and there is hypothermia. Temperature is less. What is the normal temperature range of a newborn? 5 to 37.5. Okay. So hypothermia indicates sepsis. Hyperthermia will also indicate sepsis, that is fever. But in newborn, if the temperature is less, there is hypothermia. That is also an indicator of sepsis. Then if there is distension of the abdomen, if there is vomiting, abdominal distension means what? There is some infection inside the abdomen. The baby is not digesting the feeds. That's why the baby is vomiting. There is a condition that happens mostly in the preterm newborns that is called necrotizing enterocolitis. In that condition, the abdomen is distended. The baby is not feeding well. The baby is vomiting. Baby is having bloody stools. So these are also pointers of sepsis. Okay. And apneic spells. What do you mean by apnea? Cessation of breath. Okay. Along with that, there can be bradycardia also. That also indicates it may be because of sepsis. Diarrhea is usually uncommon, but it can be present. Fast breathing, chest retraction, grunting indicate pneumonia. What is the definition of fast breathing in a newborn? More than how many? 60 per minute. Very good. 60 per minute er beshi hole. And if there is grunting, if there is chest retraction, it will indicate pneumonia. Meningitis often do not have a distinct clinical picture. Therefore, meningitis should be suspected in all cases of neonatal sepsis. So we should always think about meningitis also. When we will think about meningitis, I will explain it to you in the subsequent slides. Now again, if the sepsis is severe, the newborn can land up in septic shock. There can be bleeding manifestation. Why? Because of development of disseminated intravascular coagulation, that is DIC, that is consumptive coagulopathy. And this is a term found in neonatal sepsis called scleræma. I will show you the pictures. Scleræma means the skin is becoming thick. Okay, you won't be able to pinch the skin. That indicates overwhelming sepsis. Renal failure can be there. These are indicators of overwhelming neonatal sepsis, means severe neonatal sepsis. Usually, newborn babies who land up in these conditions are very difficult to treat. Okay, the case fatality rate, the mortality rate is very high for these newborns who show these symptoms. So this is a newborn baby. You can see the skin over the abdomen. Just try to see. The skin is so shiny, tight, and if you examine, you won't be able to pinch up the skin. Just look at this region. It is red, it is reddish, it is shiny, and it also looks tight. Okay, so this is called scleroderma. And if you observe it more, you'll be able to appreciate some amount of abdominal distension also in this picture. Now look at these sick babies. Okay, just look at, this is a preterm low birth weight baby. You can see the abdomen is distended. There is necrotic tissue in the umbilicus. So this is the source of sepsis. Just look at it, around the necrotic tissue there is an erythematous area and the whole abdomen is distended and the baby looks so lethargic. Okay, look at this baby. This is a classical textbook picture, also given in MCQs. This is staphylococcal scalded skin syndrome. Okay, the skin is all exfoliated, erythematous, baby is sick. Okay, this is staphylococcal scalded skin syndrome. This is also type of neonatal sepsis because staph is a bacteria. Okay, again look at this. The left knee joint is swollen. Okay, there is septic arthritis. This is also a manifestation of neonatal sepsis. Look at, there are so many pustules over the skin. Some pustules are normal, but there is extensive pustules. Means there is skin infection, pyoderma. This is also a form of sepsis, maybe localized, but this is also neonatal sepsis. Look at this, extremely sick newborns. Extremely sick newborns, these are, just look at the skin. There is abdominal distension, the skin is shiny, okay, and this is actually scleroderma, and also you get necrotic regions, and this baby is ventilated. There is necrotizing enterocolitis as well as overwhelming sepsis. Look at this picture. What do you see in the X-ray? Can anyone describe? Anyone comment please? I have also, there is a pointer. What is this in the lungs? Homogeneous opacity, that is pneumonia. Okay, this region, right upper lobe as well as some portion of the middle lobe also. Up to this there is so much of dense homogeneous opacity, pneumonia. What is this? This is endotracheal tube. Okay, and what is this? This is the feeding tube. The baby is on invasive mechanical ventilation. Now we will also have to know about the sepsis mimics. There are some conditions which will mimic sepsis. So we need to rule them out. What are those? Hypothermia. If the baby's temperature is not maintained, I will think no, the baby has developed sepsis. It may be because of some cold stress, the warmer was not working, okay, the mother didn't wrap the baby properly. We just need to address the hypothermia issue, okay. So hypothermia, hypoglycemia, maybe the mother was not giving feeds properly, the blood sugar fall and the baby became lethargic, mimicking the symptoms of sepsis. So these are the mimickers. Hypoxia, the baby was having respiratory distress, the baby was having less amount of oxygen in the body, that's why the baby showed symptoms of convulsions, lethargy, those things can happen. Metabolic acidosis, actually metabolic acidosis in a newborn is not only because of sepsis, it can be because of some inborn error of metabolism also. Okay, those are other group of disorders, this inborn error of metabolism. We are not going to talk about them, but we will have to rule out other causes also. When we are considering sepsis, we will have to rule out other causes also. Congestive heart failure. In heart failure also there will be tachypnea, tachycardia, fast breathing, okay, and even a simple nasal block. Even a simple nasal block in a newborn can manifest as fast breathing and respiratory distress. Therefore, what we have understood, a careful clinical examination and relevant investigations are required to differentiate these conditions from neonatal sepsis and avoid unnecessary antibiotic therapy. Okay. This is also a flow chart taken from OPGHI textbook. Just follow the chart. The font is small. Won't be able to see it from the back. Just hear what I am saying. When you are suspecting neonatal sepsis, first you will have to stabilize the baby by ensuring TABC. What is TABC? Temperature, airway, breathing, circulation. First you stabilize it. Then you assess what is the postnatal age. Less than 72 hours, you will have to check the perinatal risk factors. Okay. Now, if the risk factors are present or absent, if the risk factors are present, but if sepsis symptoms are absent, we will have to look for other risk factors. I am simplifying the flowchart because I have already talked about the risk factors in the previous slides. I am trying to simplify it. So, if there is presence of perinatal risk factor, we will look for the symptoms. If symptoms are present, we will send blood culture and start IV antibiotics. Okay. Now, if the postnatal age is more than 72 hours, we will look for the symptoms again. If the newborn is very sick, same thing. Blood culture to send blood culture and start IV antibiotics. And if the neonate is not too sick, we send sepsis screen. If it is positive, same thing, blood culture and IV antibiotics. And if it is negative, we will look for other causes. Just to simplify, if the baby is too sick, just draw a blood culture and start IV antibiotics. Now, when to do lumbar puncture, I will be discussing in the subsequent slides. Just remember, sepsis screen when it is to be done. Okay. Sick baby means what? Whatever symptoms I have talked about, the overwhelming sepsis indicators means the baby is very sick. So don't waste time for the investigation reports to come. Send the investigation, start IV antibiotics immediately. Don't delay the dose of antibiotics. Now, what do you mean by sepsis screen? Sepsis screen is a very important topic for short note. It comes, you will have to remember the parameters and the values. Sepsis screen, these are some parameters. We look for the total leukocyte count if it is less than 5,000. Absolute neutrophil count less than 1800. In pediatric population or in adults, leukocytosis, neutrophilia, those are indicators of sepsis most commonly. But in case of newborn, it is penia. Leukocyte count less than 5,000, absolute neutrophil count less than 1800, immature to total neutrophil ratio more than 20%. Usually we don't measure IT ratio, we look these parameters TLC, ANC and C-reactive protein more than 1 milligram per DL. Micro ESR more than equal to 15 millimeter in the first hour. So when we will call positive sepsis screen, positive sepsis screen is when out of those 5 parameters, 2 or more are abnormal. So 2 or more abnormal means positive sepsis screen. But if we get the sepsis screen is negative, but our clinical suspicion is strong, we will repeat screen after 12 hours. So it doesn't mean that a test has become negative once, it can never become positive. We will have to keep assessing. We will have to keep our clinical acumen strong and we will repeat the test after 12 hours. Now, in early onset neonatal sepsis, when we will do lumbar puncture? When we will examine the cerebrospinal fluid for symptoms of or signs of meningitis. In early onset neonatal sepsis, lumbar puncture is indicated in the presence of positive blood culture, or if the clinical picture is consistent with sepsis. But in late onset neonatal sepsis, LP should be done in all infants before starting antibiotics. Tale easy bhabe hocche, in early onset neonatal sepsis, blood culture positive thakle LP. But if the baby is very severe, then do LP. But in late onset, in all babies, you will have to do a lumbar puncture. Okay? Now this is a normal CSF examination in neonates. You may not be able to remember, but why have I included this table is to let you know the values are different for term and preterm babies also. The values are significantly different from pediatric population as well as the adult population. In a term preterm, up to 7 WBC, up to 9 WBC, they are normal. But normally in pediatric population, it should be less than 5. But in newborn babies, if you get up to 7 WBC or 9 WBC, those are considered to be normal. Even a range is mentioned 0 to 32, 0 to 29. In the pediatric population or adult population, even a single neutrophil in the CSF is considered to be abnormal. But here look, even 61% or 57% polymorphonuclear cells are normal. So interpreting the CSF report of a newborn is different, okay, than the pediatric population or adult population. Protein 20 to 170, on an average 90 is normal, okay. 115 milligram per DL is normal. For glucose, 52 and 50 are normal. So you need to know about the normal parameters. So whenever you will try to interpret the CSF report of a newborn baby, you will have to keep the normal parameters in mind. The reference values for neonates are different. Now there are some newer tests also like serum procalcitonin, molecular diagnostic test based on amplification of bacterial DNA, that is polymerase chain reaction. We don't do them routinely, but these are there. What is the treatment? First of all, start with supportive care. Supportive care means euthermia. We will have to maintain normal temperature, that is 36.5 to 37.5. Respiratory support. If the newborn is cyanosed, if the newborn is grunting, start with oxygen, start with ventilation, okay. Circulation, that is assess the capillary refilling time. How to assess capillary refill time, anyone? Mainly sternum er oporta bolbi. Sternum, ঠিক আছে? Capillary refill time, how many types are there? Central, peripheral. Peripheral ta kothay dekhe? Fingertip, nails, nail bed, okay? Or fingertips. Now we will also assess the skin color. We will assess the urine output. If the baby is in shock, you will have to give normal saline or ringer lactate. Bolus, that is 10 ml per kg over 5 to 10 minutes. Bolus may be repeated over the next 30 to 45 minutes if the baby's perfusion is still poor. Inotropes like dopamine, dobutamine, they can be given if it is fluid refractory shock. Do you know about inotropes? Dopamine, dobutamine, they actually act on the heart, they improve the contractility of the heart, they act on the circulation. In that way, they help in management of shock. Of course, before that, you will have to put in a intravenous line, manage the hypoglycemia with 10% dextrose, 2 ml per kg. Glucose infusion can be started if the glucose remains low. The dose is 4 to 6 milligram per kg per minute. You may not remember the doses, but just remember what is to be done. Optimal nutrition. Early initiation of enteral feeds with breast milk if there is no abdominal distension and neonate is hemodynamically stable. If the neonate circulation is good, we will start enteral feeds like OG tube or allow breastfeed with exclusive breast milk is preferable. But if the patient is in shock, we will have to keep the baby nil per mouth. Now, what is the specific care? Appropriate empirical antibiotic therapy. This antibiotic should be given to kill the bug. Should be started without delay after obtaining blood samples for culture. What empirical therapy means? It must cover the significant causative pathogens like Klebsiella, Acinetobacter, those bacteria. Okay, must cover the significant causative pathogens. Antibiotic therapy. Antibiotics are started in early onset neonatal sepsis when, if any of the following. Whatever risk factors we have talked about, if there is presence of more than equal to 3 risk factors for early onset neonatal sepsis, if there is suspected or confirmed triple I, means intrauterine infection, inflammation or both, presence of more than equal to 2 risk factors and positive sepsis screen, and a strong clinical suspicion of sepsis, start antibiotic therapy. When will you start antibiotics in late onset neonatal sepsis? If there is positive sepsis screen or strong clinical suspicion of sepsis. Therapy after, suppose you have started empirical antibiotic and after 2 to 3 days the blood culture report is coming, it is showing a culture sensitivity pattern. So according to that you will have to shift to appropriate antibiotics. Antibiotic can be specific once a positive culture sensitivity report becomes available. What is the blood culture method followed? Backtake method. Backtake automated blood culture system. What is the choice of antibiotic? We usually in our NICU we follow cefotaxime, amikacin. So here ampicillin or cloxacillin plus gentamicin or amikacin means one aminoglycoside along with one broad spectrum ampicillin or cloxacillin. Cefotaxime, ciprofloxacin or piperacillin tazobactam plus amikacin. We usually don't give ciprofloxacin. If in the examination it is asked, you just write about third generation cephalosporin plus an aminoglycoside, or we can give piperacillin tazobactam plus amikacin or even gentamicin. What is the duration? If you are getting meningitis, means CSF is positive, plus minus positive blood or CSF culture, 21 days is the duration of antibiotic therapy. 21 days NICU te thakbe. Blood culture positive, but there is no meningitis, 14 days. So after getting the positive blood culture report, you did LP, but the CSF report is normal. So you give 14 days of antibiotic. If the culture is negative, but your clinical suspicion is high, sepsis screen positive elo, blood culture negative elo, তখন কি করবে? 5 to 7 days. Now it is very important to know about the antibiotic stewardship program. Very important. What do you mean by that? Right antibiotic at the right time and dose for the right duration through the right route. So everything must be right to keep the superbugs off. Okay, because now you know it is very discussed nowadays. The superbugs have developed, normal antibiotics are not working. So how will we be able to ward off superbugs? Everything should be right. Antibiotic choice should be right. It should be given at the right time, right dose for the right duration. That means 21 days, 14 days or 5 to 7 days. Duration is important. And through the right route. That is intravenous or oral, you know. Now, how will you prevent neonatal sepsis? 6 cleans, you have learned about it in community medicine also. 6 cleans at the time of delivery. Clean hands, clean surface of delivery, clean perineum, clean and dry cord care, clean cutting instrument and clean towels. Exclusive breastfeeding, very important because breastfeeding has protective factors, okay, immunoglobulins. Colostrum is very important because it helps in prevention of neonatal sepsis. Hand hygiene among the healthcare staff. So before touching any newborn, you will have to wash your hands properly. Avoid unnecessary invasive intervention like IV access. If IV access is not required, please don't breach the skin integrity. Kangaroo mother care for stable low birth weight babies. You know about kangaroo mother care? Okay. Now we will discuss about a case. A 19-year-old woman, gravida 2, underwent normal delivery, gave birth to a 1.95 kg girl baby at 34 weeks of gestation. 34 weeks means preterm. 1.95 means low birth weight. Okay. So risk factors are present. Pregnancy was uneventful. Membranes ruptured spontaneously 6 hours before delivery, but there was no maternal fever. Newborn was born vigorous. What do you mean by vigorous newborn? That will be taught in the neonatal resuscitation class. Like heart rate is okay, heart rate is more than 100, respiratory effort is good. Okay. Now ABGAR score is 8 at 1 minute and 9 at 5 minutes. Means the baby is okay. But there is fast breathing. Tachypnea was there from the beginning. Then what happened at 18 hours of age, the baby developed severe apnea. Mottling of the skin. Mottled skin means the skin's color is becoming whitish and also pinkish. The color is uneven. At areas it is whitish and pinkish as well. That is called mottling. It means the perfusion, the skin circulation is affected. Okay. And also delayed capillary refill time. Then ultimately the baby lands up in respiratory failure and also has shock, that is metabolic acidosis. Baby was intubated and put on mechanical ventilation. Umbilical artery and umbilical venous catheterization was done and aggressive fluid resuscitation was started. Ampicillin gentamicin were begun after blood culture was obtained. Dopamine dobutamine infusion was started due to fluid refractory shock. Now we sent blood samples. The sepsis screen was done. It showed leukopenia, that is 2100. Normal was less than 5000. Neutropenia 1400. Normal is up to 1800. 1800 is tolai. CRP more than 1 milligram per dl, that is 4 milligram per dl. Chest X-ray was done. It revealed reticulogranular pattern in both lung fields suggestive of pneumonia. So the baby has pneumonia. And what type of sepsis? Early, 18 hours. So prognosis is poor. The blood culture group penicillin sensitive Streptococcus pneumoniae. Mother's vaginal swab was also positive for the same bacteria and serotype. So the outcome was poor. We started sensitive antibiotics and the baby recovered. So this is the flow chart of how we manage neonatal sepsis in our everyday practice. Okay. Take home messages from neonatal sepsis is: consider sepsis in any unwell newborn. Recognize the subtle signs of neonatal sepsis. Be aware of the common symptoms and don't rely on the fever alone. There are other symptoms as well. Start appropriate empirical antibiotics, manage in neonatal intensive care unit and investigate properly. Assess the maternal risk factors, implement strict hand hygiene and consider intrapartum factors. Early treatment is life-saving and prognosis is time dependent. The timing of management is very important. Right timing is very important. When you are starting antibiotic, don't delay antibiotics. Now the second topic is congenital and perinatal infection. We will learn about torch infections because these are congenital and perinatally transmitted. So what are torch infections? The abbreviation TO means toxoplasmosis, R is rubella, C is cytomegalovirus and H is herpes simplex virus. Other infections are also there like syphilis, malaria, tuberculosis, HIV, hepatitis C virus, hepatitis B virus and varicella. These can also be congenital or perinatally transmitted. Okay. Now we will talk about congenital toxoplasmosis. Maternal primary infection. If the mother is having toxoplasmosis, that will lead to infection of the fetus and disease. Now as the pregnancy advances, the transmissibility increases and risk of fetal disease decreases. This is a rule of toxoplasmosis. Like if the infection occurred at an advanced stage of pregnancy, the transmission will be more but fetal disease will be less. What is the clinical triad of congenital toxoplasmosis? Intracranial calcification, hydrocephalus and chorioretinitis, means retina will be affected. So this is a picture of toxoplasmic chorioretinitis. This is a fundoscopy image. You are seeing this structure. This is toxoplasma, toxoplasmic chorioretinitis. How will you diagnose it? In the babies, we will have to send toxoplasma IgM in the serum. So it will be positive, and toxoplasma PCR in the CSF or the tissues. What is the treatment? Pyrimethamine, sulfadiazine, folinic acid will be given for 1 year. Rare infection, but if it happens, this is the mode of treatment. I have prepared this in the form of short notes. I haven't told about irrelevant irrelevant facts. Just remember whatever I have mentioned. These points are important for you. What is congenital rubella? Again, rubella infects when the mother is pregnant. The transmission of rubella is highest in the first trimester of pregnancy. What is the duration of first trimester? Anyone? First 12 weeks. So first 12 weeks se jodi rubella virus ta dhoke, the transmissibility will be highest. But the fetus is spared if infection is beyond 16 weeks. 16 weeks er pore hole the chance of infection is less. What is the classical triad? Very favorite question for MCQ. The classical triad of congenital rubella is deafness, cataract and congenital heart disease. Which congenital heart disease? Patent ductus arteriosus, that is PDA. How will you diagnose? We will send blood samples from the cord or neonatal blood. Rubella IgM will be positive because there are two types of antibodies, IgM and IgG. IgM means recent infection. IgG may be positive. IgG means the infection might have occurred before. It is not recent. Okay, IgM means there is current infection. But unfortunately, there is no treatment of congenital rubella. We will have to treat the complications like deafness, cataract and PDA. Diagnosis of rubella, if it is done in the first trimester of pregnancy, it is an indication for medical termination of pregnancy. Okay. Therefore, pre-conceptual counseling is very important. Rubella IgG should be done before conception. If the IgG is negative, we will have to give the measles rubella or mumps measles rubella vaccine. So IgG থাকা মানে কি? আগে ইনফেকশন হয়েছিল, এখন অ্যান্টিবডি আছে অলরেডি, তাহলে we don't need to vaccinate. There is no active infection, but আগে হয়েছিল, the antibodies are there. The mother has been exposed to rubella, so IgG আছে মানে ভালো, ঠিক আছে? If IgG is negative, we are active immunization by MR or MMR vaccine. They will induce production of antibodies. MR vaccination should be done for adolescent girls. When national immunization program will be taught, you will learn about the adolescent vaccines, which vaccines are important to give in adolescent. Then universal immunization program of India also carries out MR vaccination campaign, measles rubella vaccination campaign. Now we will talk about cytomegalovirus. Cytomegalovirus, perinatal cytomegalovirus we will talk. The transmission is more with primary maternal infection than reactivation or reinfection in mother. Cytomegalovirus can undergo reactivation also, but prothom infection, primary infection e beshi transmission hoy. In India, 99% of the mothers are CMV IgG positive. Congenital infections are due to reactivation or reinfection. So this is a paradox. Transmission is more with primary maternal infection, but congenital infections are more due to reactivation, reinfection. Okay. Transmission occurs throughout pregnancy. এখানে কোনো ট্রাইমেস্টারের রুল নেই. Throughout pregnancy transmit হয়. Disease will involve multi-system. Cytomegalovirus can affect any system of the body. Periventricular calcification is characteristic of cytomegalovirus. I will show you the picture. This is the periventricular calcification. This is a classical picture for MCQ, image-based question. This type of periventricular calcification is found in which infection? Cytomegalovirus infection. Then sensory neural deafness can be found. How will you diagnose? You send urine, positive IgM in blood or urine. Urine, cytomegalovirus is excreted. It is shed. Okay. Or cytomegalovirus PCR in the first 2 to 3 weeks of life. So how will you diagnose? Send blood for IgM and send urine for cytomegalovirus PCR. Polymerase chain reaction will detect the nucleic acid of cytomegalovirus in the urine. What is the treatment? Ganciclovir if you want to give injections, or valganciclovir. Valganciclovir is given for 6 months. It is given orally. Tablet পাওয়া যায়. So cytomegalovirus transmission during delivery and breastfeeding, breast milk shed hoy. And it is more common in preterm very low birth weight baby. Very low birth weight definition bolto keu? Koto বেটের তলায় VLBW? বললি তো একজন বললি আর বল হ্যাঁ 1.4. Then the patients can have anemia, thrombocytopenia, hepatosplenomegaly. Okay. So these are the clinical features of cytomegalovirus. Now we will talk about herpes simplex virus. How we are talking about perinatal herpes simplex virus. So transmission to babies occur during delivery in the mothers who develop primary genital herpes before or at the time of delivery. Because ওই lesions গুলো তো genital region এ থাকে, লেবারের সময় হয়, ঠিক আছে, তার আগে ঠিক থাকে. So there are 3 forms of herpes simplex virus disease. There can be vesicles eruption in the skin, in the eyes and mouth. There can be meningitis also, which is very bad. If there is meningitis, there will be seizures and altered sensorium, and there can be disseminated disease, like it has all sprayed inside the body. How will you diagnose? You have learnt about this in microbiology classes. Which smear? Zank smear. Skin lesion থেকে কিছুটা স্যাম্পল নিয়ে পাঠানো হয়. We use Zank smear. Zank smear এ দেখা যায়. Or you can send culture or polymerase chain reaction of cerebrospinal fluid. That because PCR will detect the nucleic acid of herpes simplex virus. What is the treatment? IV acyclovir. Acyclovir, what is the dose? 20 milligram per kg body weight. 3 times a day. Duration is 2 to 3 weeks. Followed by 6 months of oral acyclovir to prevent reactivation. Because herpes simplex virus abar reactivate hoye jay. Then what other thing we can do? Elective cesarean section in mothers with active genital herpes and unruptured membranes. CS করলে genital tract দিয়ে travel করতে হচ্ছে না বেবিকে, তো ইনফেকশন হবে না. Therefore, careful examination is very important. This is mainly done by obstetricians. Now we will talk about congenital syphilis. All mothers should be screened for syphilis by VDRL test or rapid plasma reagent test at least once in pregnancy. If you go through the mother and child protection card given by Government of India, you will see VDRL test is written. You will have to test it. If the titer is more than 1:8, you will have to perform a specific test, that is Treponema pallidum hemagglutinin acid, TPHA or TPPA. You have learnt about it in microbiology, remember. This Treponema pallidum is a spirochete. Okay, it should be done to confirm. What is the treatment? Infected mothers should be treated with benzathine penicillin. And maternal syphilis transmitted throughout pregnancy. It is more during the later pregnancy. What are the clinical features? The newborns can have bone lesions. The newborn can have snuffles and pneumonia or bullous lesions on the skin. There can be depressed nasal bridge. There will be central incisors will be notched. There can be keratitis, means corneal inflammation, and sebar shin. The shin bone, there is a deformity that is called sebar shin. Bony lesions are there, and frontal bossing. Okay. So treatment is again penicillin. Okay.